Welcome to this medicine masterclass on polycystic kidney disease. Let's start off with the history. Patients may present with acute loin pain and hematuria and recurrent stones, and that's as a result of the cysts on the kidneys rupturing or spontaneously hemorrhaging. They may also convey a family history of polycystic kidney disease, or importantly, a family history of other aneurysmal conditions such as subarachnoid hemorrhage and berry-aneurysms. On examination, they may have signs consistent with chronic kidney disease. They may have anemia, they may have an AV fistula, they may have a third nerve palsy which is non-pupil sparing as a result of a berry-aneurysm, or they may have conjunctival pallor from anemia. When you examine their abdomen, you'd expect a large blottable mass on each side, and you should be able to get above it, and this is a large kidney. In the lower abdomen, if they've had a transplant already, look for a Rutherford-Morrison scar. Be aware that polycystic kidney disease has two key forms. Polycystic kidney disease form 1, which is a defect of chromosome 16, and this is about 85% have this condition, and the mean age of dialysis or transplant is about 57 years old. PKD type 2 is an abnormality on chromosome 4, and this is rarer. About 10% of patients present with this defect, and the mean age of dialysis is or transplantation is about 69 years old. If a patient who's a relative of a patient with polycystic kidney disease has a negative scan at the age of 20, there's a 90% confidence that the patient will not develop polycystic kidney disease. Polycystic kidney disease is associated with other cystic and aneurysmal conditions, in particular liver cysts, pancreatic cysts, berry-aneurysms in the cerebral circulation, mitral valve prolapse and aortic regurgitation, as well as polycythemia, anemia, and hypertension, and accounts for 10% of dialysis patients in the UK. To investigate these patients, a number of blood tests are required, including a renal screen. Assess for anemia, regularly monitor the U's and E's, the LFTs, the CRP looking for any signs of infection, autoimmune screen to look for complement levels, autoimmune antibodies such as ANA, ANCA, double-stranded antibodies, anti-GBM antibodies which can cause Goodpasture syndrome, as well as fluid dip, the urine MCNS, urinary Bence-Jones proteins, as well as protein to creatinine or albumin to creatinine ratios to help monitor the renal function. Imaging, renal ultrasound, or CT scanning of the abdomen is an important way to define the kidney structure. For specific diagnoses, a renal biopsy would also be required. To manage patients with polycystic kidney disease, remember a holistic biopsychosocial MDT approach is required. Conservatively, optimize any of their comorbidities, particularly diabetes, hypertension, glomerulonephritis, advocate smoking cessation and alcohol cessation, advise them to increase their water intake and reduce their salt intake, and provide genetic counselling. Ensure that you advise them to avoid high-impact supports to reduce the risk of abdominal trauma. Medically, ensure that their blood pressure is very well controlled as well as their cholesterol, offer ACE inhibitors for patients with high blood pressure, and prepare them for surgery. Patients may require cyst aspiration or nephrectomy for recurrent cyst hemorrhages. A renal transplant may be required for patients with advancing kidney disease early on, and a preemptive renal replacement therapy with a fistula is cited in these patients. Patients who have renal transplant do not necessarily have the polycystic kidneys removed. Before they have their surgery, they may have renal replacement therapy when the GFR drops to less than 15 mils per minute, and they will undergo a process of education and counselling, and the selection of peritoneal dialysis or haemodialysis is based on the patient motivation, desire, as well as the availability of the resources. Peritoneal dialysis, as you can see demonstrated here, uses the peritoneum to dialyze the patient. This process removes excess fluid and toxins and helps correct electrolyte imbalances. A catheter is inserted into the abdomen. A specific solution is introduced which has high levels of glucose to maintain a concentration gradient. Solutes diffuse across the diffusion gradients, and the fluid is then removed. The complications of this, because you're introducing a foreign body into the abdominal cavity, include infections, peritonitis, hernias through the weakened abdominal wall, as well as the risk of intra-abdominal bleeding, the blockage of the catheter, sudden hypotension due to the fluid movements, as well as cardiac instability and hypertriglyceridemia. A more advanced form of dialysis is hemofiltration, and this is used for acute renal support, commonly seen in intensive care units or renal units. Blood is continuously filtered across a highly permeable synthetic membrane, allowing the removal of waste products by convection. The ultrafiltrate is replaced with an equal volume, and this system allows you to remove fluid from a patient as well as waste products. In summary, we've discussed the history and examination findings for patients with polycystic kidney disease, confirmed that there are two key types which lead to renal failure in a different time frame, and the management options that are available, including dialysis and the various types of dialysis, as well as the surgical interventions that are required. Thank you very much for attending this medicine masterclass.